And like I had said before, whether you want to go system by system by system, that's fine. Or if you want to go starting at the head and work yourself down to the toe. When you're doing this for us, you're going to be verbalizing a lot of different things to us. You're going to be telling us why you're doing it. But when you go to clinical and you're doing this in clinical, don't be sitting there telling all this information to the patient. Keep it as realistic as you possibly can. But do try when you're doing the physical assessment to focus in on the patient. So when you do come in and I've washed my hands, I've done the sanitizer, and I've identified my patient, he said his name and date of birth to me, and I checked it. So I know I have the right type of patient. I'm gonna do just some casual talking with him just to see, you know, what he's in the hospital for or what he's doing here in the emergency room or at the clinic, just to see what's kind of going on with him. When I'm doing that, I'm looking to see if is he alert, orientated, to person, place, time, is his speech clear, is he cognitive, is he aware of what's going on? You're just doing some mental notes like that as to how he's doing neurologically. So we'll do that. Well then, as long as I'm starting head to toe here, I'll just have him look straight ahead, and I'm gonna check for Perla first. Perla, pupils equal round, reactive to light, and I will check accommodation. So I am going to dim the lights, and then I'm gonna come in from this side, look to see if it constricts, do it again, see if this side constricts. I'm gonna come over here, keep looking here, and I'm gonna look to see if it constricts, and look to see if the other one constricts. If they're both constricting, brisk, equal, they're round, then we've got our Perla and we've got a consensual response when they both constrict like that. So I've got that going. Another thing I might want to do, I don't have to have the light on, I'll have him look at this. I'm going to check cardinal signs. And I'm just going to have him not move his face, but just follow the pen light. And I'm looking to see if there's any nystagmus going on, making sure that there's no, the eyes aren't like wiggling and jiggling and spazzing out in there. So it just, you know, you don't have to do all 9 areas or whatever it is, but just do a few just to see if they're able to follow. I'm seeing if he can follow commands as well. The last thing then would be accommodation. And remember, if you don't do accommodation, don't chart it. Just do Pearl, not Perla. So Perla, accommodation, I'm gonna have him look at this. I'll go in a little bit, and then I'm gonna come back. You don't have to go all the way down to his nose. We're not looking to see if he can go cross-eyed. All we're looking for, again, are the eyes coming in a little bit, and they'll constrict a little bit when you do that accommodation as well. And then do they move out? I think I've got that going okay. When I'm looking at the face too, and his skin in general, I'm looking to see what kind of color we have going on, because that's respiratory and cardiac. You know, is he dry? Is it wet? What color do we got going on? You know, and we'll get more into that later with cardiac, but I'm looking at that as well. Is his skin intact? You know, these are all things that we do all the time. We just don't even realize that all the stuff that's going on in our head. I think I'm okay with that. I'm gonna go down now towards the neck, and some of the things in the neck. First, I'm gonna check to see the cardiac pulse, one at a time, and I'm gonna feel, kind of grade it to see if it's strong or weak. Do the other side, see if it's strong or weak. Another thing I might do is have them look that way. And then I would elevate the head of the bed a little bit, and I'm going to check for some jugular venous distension just to see if he has any. If he has some, then I'm going to go ahead and get my little rulers out and I will measure. But we're going to say that I took a peek here and I don't see any type of jugular venous distension. As long as I know that you've checked for this, then we're okay. So then back with the carotids, I'm going to take a quick listen. I'm just going to put my stethoscope here so I can keep hearing and talking. And I'm going to listen. And what I'm listening for is if I hear any type of rushing going through. Do I hear any bruits? You know, because this is indicative if there's any type of occlusions going on in the carotid arteries. So I have palpated, and then now I've listened to both sides. And I checked jugular venous distension. So I think I'm okay to down here. But now, as long as I'm listening, let's go to cardiac. So I'm going to listen with my diaphragm, and I'm going to listen to all the valves. So you're going to tell me which valves, and I'm going to do my ape to man. So my aortic is my second intercostal to the right of the sternum, and then I'm going to go to pulmonic, second intercostal to the left of the sternum. Then I'm going to check herb, just because herb's place is a really good place where you can hear murmurs if there are any. It doesn't tell you specifically where the murmurs are, but it just kind of gives you an idea. So herbs is about the third intercostal to the left of the sternum. Then I can do tricuspid, which is about the fourth or fifth, either one is okay, fourth or fifth intercostal to the left of the sternum. And then your mitral is on the left side, mid-clavicular, fifth intercostal. And I'm gonna listen there as well. When I'm listening to all these areas, these landmarks that you'll tell me, I'm listening to, is the apical rate equal? Is there any missed skip beats? Is it irregular? Do I hear any swishing sounds? Do I hear any clicks? Any type of those things. That's what you're not just listening, but what are you listening for? So that's what I want to hear from you, is what you're listening for. When I'm doing cardiac here as well, I can feel to see if I feel any lifts or heaves. You know, do that over the precordial. Am I feeling any of that? Nope. That is good. We've got S1 and S2. So remember, S1 is the mitral and tricuspid closing. S2 is up here where your aortic is, and that's your aortic and pulmonic valves closing. Because remembering, if they're not closing very well, or if they're not opening very well, that's when you're going to hear different sounds. Make sure you're listening for S3, S4. Those are all the things that you're listening for while you're doing this. So I think I got that auscultated. As long as I'm listening and I'm kind of doing cardiac here and abdomen, I think I'm going to go ahead and listen down here as well. So a few things I'm going to listen for. I'm going to start with the right lower quadrant of the abdomen. I'm going to start listening for bowel sounds. So I'll listen, then I'll go up, and you're just kind of going the way that the bowel goes until I hear it. You're like, oh, okay, there I heard some. Now I'm just going to listen for a little bit and just kind of get a feeling, do I have hypoactive or do I have hyperactive bowel sounds? So I'm going to listen for about a minute and just see what I get. But let's just say I don't hear anything in all four. Then you do have to listen for 5 minutes before you can, not 5 in each quadrant, but just a total of 5 minutes before you can actually supposedly chart no bowel sounds present. So I've gone around there. Then I'm going to flip and I'm going to listen for the vascular sounds. You know, your aortic vascular sounds, renal, femoral. So what I'm listening for again is, do I hear any type of swishing sound? Because it'll almost sound like, if you want to compare it to like a murmur, something on that order. But that's the vascular sounds that you're listening to. When I'm doing this, I listened, but I probably should have maybe looked, but my listening didn't affect what the abdomen looks like. I'm looking at the abdomen. You know, do we have any distension going on? Or is it concave? Or is it just flat? And, you know, I can just lightly touch. Is it firm? You know, is it distended? Is it hard? Or is it soft? So those are some things you want to look at as well. Now I can push a little bit because I've already listened, so I'm okay. So let's see, what's another thing? Okay, I'm going head to toe. I listen to my heart sounds. I listen to my abdominal sounds. I listen to my vascular sounds. I can go with a little bit of aortic and venous type of things as long as I'm doing cardiac here. And that's mainly like with the lower extremities. So I'll look here. I'll look to see if he's got any sores. If he's got any sores like on his toes, we know that they're kind of a ischemic looking, necrotic, dry, small on the toes. We've got some arterial problems. If he's got some on his medius ankle area, then we know it's more of a venous. If his feet are cold, we know it's probably an arterial. If it's really warm, it's probably a venous. If he's got good pulses, we know it's probably a venous. If it's poor pulses, we know it's probably arterial. So those are just some ideas. You're trying to get an idea if they've got any venous or arterial problems going on by looking at their feet. When I'm down here at the feet, I might as well check those pulses. Dorsalis pedis is on the top. Posterior tib is more in the ankle area. And we grade them. What kind of pulses do we got going here? 2+, 3+, 4+. You know what's good. I'm going to also look for edema. And if they do have edema, I'm going to measure it according to how many millimeters it goes down. I can check for capillary refill. You can do it on the hand too, I'm fine with that, but on the toes gives you a really good inclination. If it's going greater than 3 seconds, we probably have an arterial problem. And if it's less than 3 seconds, then we're okay, or it could be venous. Either way, so I checked for capillary refill, checked for the temperature. Maybe I can go back up. Now I know I'm going kind of back and forth with all my systems, but I haven't moved my patient. He's still okay, he's laying down, I'm not making him go all over the place, so we're okay. I'm gonna listen to his lungs. So, you know, it's kind of hard to show on here, but you're gonna be starting at the top because your lungs are way up here. So you're gonna start and just have him take deep breaths in and out, in and out. And then you're gonna go down, in and out, across, in and out, down. So just so you get that pattern going. Don't go all the way down, all the way down. Go back and forth because then you're comparing bilaterally. So if they do have any type of wheezes, which would be more expiratory, or if they have any crackles, you could hear it inspiratory. So you can measure more and see where they're exactly out. So I'm gonna go out on the front side, then I'm gonna listen on the sides. Make sure you get in on the sides, both sides. I'll wait to the back for later. I'm looking to see how they are breathing. Do they look like they're having troubles breathing? You know, because sometimes you feel like I'm breathing okay, but the nurse can look at you and like, no, you're not breathing. So ask them, do you feel like you're short of breath? Do you feel like you're doing okay? Are they using accessory muscles? Are their shoulders going up and down? Because then they're having some dyspnea. I'd look at the rate, see if the rate is okay. With my apical pulse that I did, look at the rate, see how the rate is, see if it's within defined limits for that. So I listened to the lung sounds. I also want to listen for voice sounds. As long as I'm listening here, might as well keep it up. So a couple of them would be your egophony. For egophony, I'm going to have the patient say E, and each time he says E, I'm going to be listening and going down. E, E, E. And if he has no respiratory problems, you should be able to hear E as we go down. If it turned into an A type of sound, then he probably could have some consolidation problems. Another is bronchophony, and then we can do the blue moon and have him saying blue moon, blue moon, blue moon, and it should stay about the same unless he possibly has some consolidation that's going to get louder. There's the whispered pectorquility, and then you're going to say 1, 2, 3, and it's going to be really soft, soft, soft. If there's any issues, it's going to get louder. So we listened to different things, and I looked. I could palpate because I'm going to check for a tactile fremitus, and just make sure you're using some type of ball area of your hand, because then you can feel it the best. So whether, it's kind of hard on the front side, mostly for women, but on the back side, because you're going to do it front and you would do it back. And as long as you tell us, whatever I do respiratory on the front, I'm definitely going to be doing it on the back. Make sure you let us know that, because if it's easier on one side or the other, then that's the side that you could pick. And maybe I'll wait till I set them up, because you do get a better assessment, I always feel, on the back side, the posterior side, mostly for women, and we all know that. So I think I did enough with respiratory until I set them up. But I also want to look at the dimensions, your AP dimensions, do we have it a 1 to 2 as far as that goes? Because you can just assess for that by looking at it. And I think that's all I was going to say there. And vascular sounds, ball sounds. I could go ahead and do a couple of deep tendon reflexes when he's laying down like this. I could do my brachial by putting my finger on the antecubital and holding down on the tendon and giving it a hit. And what I'm looking for is just to see if there's any type of twinge. It doesn't have to be doing anything huge, just a little twinge of the arm. Brachial. If I wanted to do the triceps, I'd probably have him sitting up to do this, but as long as I'm talking about it, I might as well. He's really flexible. And we got him with his arm like so, okay? And then you're hitting back here, and you're just looking to see if we've got any twinging going on. So we've got, those are 2 of them. see if there's anything else I can do when I've got them laying down like this. I think what I'll do next is probably sit him up and hope he doesn't fall. Cute. Let's see, let me come over. There we go. Just don't fall on me. Okay, I want to look for chest expansion. So just make sure down here in the lower thoracic area, you're going to pinch some of the skin together. And then you're going to have him take a deep breath. And obviously it's not going to be going like that, but you're going to pinch it together, deep breath, and you're just going to see, is it expanding equally bilaterally? So then that's what I would do. Just pinch it up and take a deep breath and see if it goes that way. Tactile fremitus, then back to that because it is easier on the back. And you would just take, like I said, some more paddy area of your hand, whether it's the pads or the heel or the side, and then you're just gonna 99, 99, 99. And if he doesn't have anything going on really, then we have got, it's normal. If it gets worse as you go down, if it gets more prominent, you can feel it more, then we probably have some consolidation. So you're doing that. So we did the chest expansion, we did the 99. You could do your A, your egophony, and go back and forth. So like I said, you start, you go over, down, over, down, over. Make sure you take that pattern, just Z, back and forth. And if you didn't get a good on the sides, make sure you get your sides here when you're listening as well. Percussion. That's one thing we could have done earlier, but I'll go ahead and do the diaphragmatic excursion here. And are you sitting okay? Good. You can use your hammer, or you can use your stethoscope, or you can use your finger, whatever you want to use to do any type of percussing. So first what I'm going to do is just percuss the lung. Okay? So we'll just start. I should be hearing resonance if we got everything going on okay. And just make sure you're in the intercostal spaces when you're doing this, because if you go over a bone, then it's going to hear more flat tone. If you're going over more dense areas, then you're going to have more dullness. So you're going to do your percussion all the way down, hearing the resonance. So then maybe what I'll do, I'll say, now take a deep breath. Okay, so resonant, 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 dull. Okay, I'm stopping there. Take my little marker. Let your air out. And then I'm going to go, okay, dull, dull, resonant. There's the lung again. Mark it. And then there is where my diaphragmatic excursion is. Should be about the 5 centimeter area. So I did that. I think I'm going to have you lay down. I think I've done everything back here that I was going to do. Let's have you lay down and I'll finish my percussion. Typically, when I was doing the abdominal assessment, it is best if you do put a pillow underneath their knees because it relaxes their abdomen more. So that would have been something that I could have done to get a better assessment. Now, I would percuss on the lungs. Here again, same way as I did on the back. Go ahead and percuss. Should be hearing resonance. When I go to the abdomen to percuss, if he doesn't have anything going on, we should hear tympany. So then I'm just going to take where his abdomen would be. I would bring the covers up and just expose his abdomen, and then there again should be tympany. Now if I hit some dullness, if I hit dullness over here on the left side, then it could be that there's stool there. We're not sure, but that could be an indicative of it. There's, you know, colon is full of stool. Otherwise it should be tympany. If it is full and distended, full of air, would be hyperresonance. If, I think that's about it, because then when you get in the resonance up here, I'm gonna, for my liver, I'm going to percuss, and if I started up on the top here, I'd be percussing, and I'd hear resonance, resonance, dull, mark it, that's the beginning of my liver. Then I'm gonna keep going dull, 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 tympany, oh, there's the end of my liver. Mark it. Should be 6 to 12 centimeters. That's where you're marking your liver. I haven't done any type of palpation into the abdomen yet, and I would want to save that till later. You know, I'm looking to see if he's doing any type of guarding, because then if there's guarding, there's probably something going on in the abdomen. We really don't want to be pushing down really hard. So, but the things that I could do is to check for the liver size to make sure that we don't have it too big, you know, and you're pushing in while they're taking a deep breath and letting it out, and you're just gonna see if you're able to feel the tip, like 3 centimeters, just the tip of that liver. Or you could go ahead and do the hooking method. Either way is fine. If you wanted to check for the liver or for the spleen, you would just creep your way with your, you know, palpating down there until you got to the area they could take a deep breath and let out, and you shouldn't feel anything. Don't want to feel the spleen. Then we could, if they were suspecting of meningitis, you know, just to make sure that you know the meningitis ones, there is, you want to check for nuchal rigidity, see if they're able to bring their neck down, and if it's stiff or hurts, there you got positive nuchal rigidity. There's Koenig's, and where you're bringing it up and you're just trying to extend the leg. If there's resistance, pain, anything of that sort, then that would be positive. You could do the Brudinsky, you know, where you're taking the end of this and you're doing your upside down J on their foot, and it should either do nothing or curl, and that's okay. Don't want any flaring on an adult. Long as we're with the leg and doing things like that, we could, if they were suspecting of appendicitis, then you could do your obturator, which is you're rotating it. You're rotating for obturator and making sure that there's no signs at McBurney's point. You could do just a rebound, Bloomberg I believe it is, rebound, and don't push right where the appendix is, but over here. When you push down, it really doesn't hurt until you let go, and then you've got that rebound pain. That could be indicative of appendicitis. Ileopsis. Ileopsis is when they try to push up and you're pushing down. It irritates that muscle if they have appendicitis. So I think I got all those. I think I got almost everything. I'm sure you guys will let me know if I missed something. But then when I was done, you know, I'd let them know. I'd make sure the side rails were up, call light was in place, that they were, you know, comfortable. I think I'm okay. So that would be the end of your physical assessment within 20 minutes.